Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. In this session we're going to review chest trauma as an overview and burns, or if you want to think of them as thermal injuries. Now chest trauma by definition is defined as any form of physical injury to the chest which includes the ribs, the heart, the lungs and any underlying organs. Now the chest injury can occur as a result of an accident or a deliberate action. And as we mentioned previously in another Learn Shop, there are four major mechanisms of chest injuries. And these are blunt, penetrating, blast or inhalational. We're only going to cover really blunt and penetrating in this session for chest trauma, as they're the most common. Chest trauma categories that we're going to mention are blunt, and this is any type of injury caused by coming in contact with a solid object and that causes increased intracranial or chest cavity pressure. And the common causes are a motor vehicle accident or falls. Penetrating means it goes through the skin. So this pierces the chest cavity by a foreign object, whether that be a knife or a weapon, a bullet, gunshot wound. The common causes are exactly that, knife and gunshot wounds. Now what's the etiology of potentially life-threatening injuries? And I'm just including a few here. There are numerous others. You've got open pneumothorax, tension pneumothorax, hemothorax, a flail chest, a cardiac tamponade. Now, an open pneumothorax is usually the result of a penetrating chest injury. And then there's an opening through the skin or from the outside, the environment, into the pleura. Tension pneumothorax is a little bit worse than that. And this is a pneumothorax that causes compression of the lungs, the heart, the aorta, and structures in the chest wall, even the trachea. And this is now a lot of air accumulating in the pleural space and it can't escape. And as a consequence of that, it squashes everything, compressing it. Then you've got hemothorax. And this is any injury that can cause a buildup of blood in the pleural cavity. Heme thorax, blood in the chest. And it's not in the lungs, it's in the chest, which is the thorax, which is the pleural space. Then you've got a flail chest. Flail, this is when you've got a fracture of two or more ribs, and this results in paradoxical breathing. When you breathe out, the flail moves in, which normally it doesn't do. When you breathe out, the flail moves out, which it normally doesn't do. So this is a fracture of two or more ribs in two or more places, causing each section of the rib cage to become detached from the chest wall, resulting in paradoxical, which means opposite, chest movement. Cardiac tamponade, or tampon in the Latin, is basically pressure. So what you've got is now blood filling the pericardial sac, and because of this, it causes the heart to fail to contract effectively. And as a consequence of that, it's being tamponaded, compressed, pressured, and it can't fill and empty properly. An extension of a cardiac tamponade is an effusion, but an effusion usually occurs over a period of time for different reasons. Cardiac tamponade suddenly occurs. Here's an example of a pneumothorax. A pneumothorax, as I said, can be caused by any chest injury, and this can cause all or part of the lung to collapse. The image that you can see where the arrow is on the chest x-ray the white area there, that's the lung being collapsed. The black area is now the pneumothorax. Compare it to the left side. The left side's normal. The right side is abnormal. This is a tension pneumothorax on the left side. You've got a large collection of air, the blackish, on the left side, compressing the lung, the whitish, pushing the heart over to the right side, and even pushing the trachea to a certain degree. Now, a tension pneumothorax can be caused by any chest injury, and this can cause collapse of part or all of the lung. But however, because it compresses the heart and the blood vessels and the other lung and the trachea, this can result in cardiogenic shock and respiratory failure. Here's a hemothorax. Look at the right side. The right side, the lung is white. And as a consequence of that, if you have the history and physical assessment that says now there's chest trauma, then what you've got now is a collection of blood in the pleural space. Not in the lung, in the pleural space. Hemothorax is a collection of blood in the thorax, which essentially is the pleura. Here's cardiac tamponade. Cardiac tamponade is defined as a collection of fluid in the pericardial sac, which normally in the pericardial sac, pericardial fluid's probably only about 30 to 50 mils. At a guess here now, I'm looking at probably around maybe 200 mils of blood in the pericardial sac. And what that does is compress the heart so it cannot beat properly, empty, diastole and systole, empty, systole, diastole fill, and therefore cardiac output will be affected, and this will cause cardiogenic shock. When we look at chest trauma, the pathophysiology results in morbidity and mortality because of injuries related to being blunt or traumatic in most cases. And this interferes with breathing and circulation, or sometimes even both. Breathing, the lungs; circulation, the heart. So respiration can be compromised by direct damage to the lungs or airways, and typically pneumothorax, hemothorax, tension pneumothorax, and altered mechanics of breathing as a result of flailed chest, paradoxical, opposite mechanics of breathing. Or, in relation to the circulation, the blunt cardiac injury can cause bleeding and it can cause cardiac tamponade. What's the clinical presentation? Well, it varies, but typically there will be pain, shortness of breath, tenderness possibly in the area, maybe some visible bruising or ecchymosis on the affected side, and certainly respiratory distress. If it's a flailed chest, there will be visible paradoxical breathing, which means here you'll see during inspiration the flail will move in instead of out. The normal parts of the chest will move out. With pneumothorax, you'll have decreased breath sounds. Percussion will demonstrate hyperresonance. There may even be subcutaneous emphysema, which can be palpated. And certainly on chest x-ray, you'll see collapse of the lung. Tension pneumothorax, same as pneumothorax, decreased breath sounds, but it's a little bit more severe. And there may be hypotension or shock present, and there may be an elevated JVP, a jugular venous pressure or pulse that is visible. With hemothorax, look, there'll be decreased breath sounds or absent breath sounds again. There may even be signs of shock as a result of loss of blood. And when you percuss, there will be a dull sound during percussion on the affected side. In cardiac tamponade, well, you're not really going to know very much other than your vital signs, and hypotension or shock, decreased tissue perfusion, cold, pale, clammy skin, increased capillary refill time, agitation, anxiety, may all be present. And you may even have an elevated jugular venous pulse or pressure. What's the assessment? Well, it depends. You will be doing both, probably, respiratory and cardiovascular. When it comes to the assessment, which can be also associated with history, well, with respiratory distress. The cough may be present. This can be without blood-stained sputum. They may be cyanosed in the worst situation. Tracheal deviation, absolutely, with tension pneumothorax. You may actually hear air escaping from the chest wound, penetrating injury, and you may even have decreased breath sounds on the affected side. Absolutely, they'll be hypoxic, so the SpO2 will be decreased. And look, if they've got pulmonary edema, they may actually have frothy secretions because, again, the damaged lung may be penetrated as well. Cardiovascular, well, again, rapid weak pulse, hypotension, the skin and neck veins, jugular venous pressure is elevated. Muffled heart sounds. They may have chest pain or cardiac arrhythmias or dysrhythmias. And when you look at them, you look at the chest here, there may be bruising. There may be abrasions. There may be an open chest wound. Or there could be a chest wound that's closed. And you may see it as maybe a flail. What are some of the diagnostics? Well, history and physical assessment are absolutely important, and certainly a chest X-ray, computerized tomography, CT scan, MRI, sometimes even ultrasonography, and certainly other tests could include arterial blood gases, cardiac markers to eliminate or identify cardiac trauma, an ECG, 12-lead ECG, which could identify cardiac trauma as well. But history and physical assessment are most important. What's the medical management? Well, again, it depends on what the cause probably is. But as we mentioned previously, the treatment is aimed at preventing further damage, injury, deterioration. And again, the treatment for specific injuries with respiratory stress, things like tension pneumothorax, immediate needle decompression from someone who's an expert. Hemothorax can be now a chest tube, thoracostomy, open pneumothorax, a dressing initially, followed by a thoracostomy with insertion of a chest tube. Flail chest, well, again, really will probably be intubation and mechanical ventilation if severe. Cardiac tamponade, pericardiocentesis, which again basically is needle aspiration. Hypovolemic shock, fluid resuscitation would be most important. And other supportive palliative care, pain relief, analgesia, sedation, decreased anxiety, oxygen therapy, intubation, ventilation if required. That leads us now into burns, thermal injuries. So defined, thermal injuries are burns where tissue damage results from heat, overexposure to the sun, radiation, chemical or electrical contact. And they can be minor, moderate or severe. And again, treatment depends on how severe the damage is and where the damage is. So essentially you've got three types of burns, generally. First degree burn affects the outer lower of the skin, the epidermis. And this may just be something like redness and a little bit of tenderness. Second degree burn affects the epidermis and the second layer of the skin, the dermis. And this can be seen as swelling, redness, blisters, and more severe pain. And if it's deep, it can cause scarring as it heals. A third-degree burn involves all the areas. It involves the epidermis, the dermis, and the subcutaneous or fatty layer of the skin, and this can involve the nerves and sometimes even the bone. And the skin can be seen as being black, Escher, brown, and even white. What are some of the types of thermal injuries? Well, as we said, you've got 3 degrees, first, second, and third. However, these can be caused by chemicals, electricity, fire, radiation, steam, and hot liquids, and actually contact. What's the etiology? We said fire-related are open burns, scalds are related to steam or hot liquids, contact could be that you're touching something hot, a kitchen pot, glass, or someone is abusing you, or you're abusing yourself. Electrical is to do with electrical currents, radiation from the sun, or ultraviolet radiation, or maybe you're tanning yourself. Chemicals can be strong acids, lye, paint thinner, gasoline, a lot of the cleaning agents that may be used with janitorial staff or even in the home. Assessment, let's look. First degree burn, the epidermis, redness, peeling, pain, no scars. Second degree, epidermis, dermis, has redness, peeling, blisters, pain, possible scarring. Third degree, all 3 layers of the skin, epidermis, dermis, subcutaneous, and it can involve things like the nerves, the muscles, even bone. And it can appear as black, white, leathery, and depending on how bad the burn is, you may not even have any pain because the nerves are all damaged. But typically you do have pain and there will be scarring. A very effective tool for working out the degree of body surface area burns is called the rule of 9s. And this divides the body surface area into percentages. The front and the back of the head equal 9% of the body surface area. 4.5 for the front, 4.5 for the back. The front and back of each arm and hand equal 9% of the body surface area. So that means 4.5 for the front and 4.5 for the back. The chest equals 9%. The abdomen equals 9%. So the whole front of the chest and abdomen equal 18%. The back and the lower back are 9% each. So in total, they are 18%. The front and the back of each leg and foot equal 18%. So therefore, front 9%, back 9%. And the genital area equals 1%. In total, 100%. When it comes to thermal injuries, what's the management? Well, the management can be water-based treatments, fluids, intravenous and oral, to prevent dehydration, pain and sedatives, or anxiolytics, such as narcotics, especially anxiolytics and narcotics during dressing changes, which can be painful. There can be burns, creams and ointments, especially antibacterial, because remember, the skin is our primary defense against organisms, pathogens entering our body. Dressings in an appropriate burn centre, IV antibiotics, which are given in an appropriate burn centre, and possibly tetanus vaccination, depending on the etiology of the thermal injury. When we come to correlating our rule of nines, it comes together with what is called the Parkland formula. And this is really for fluid resuscitation and management. And fluid resuscitation is critical in the management of moderately and severely burned patients, especially with those with greater than 20% total body surface area affected, because the mortality is a lot higher in these patients. Now, to calculate the total amount of fluid to be infused, you've got to be able to work out the patient's body surface area that has been burnt, which we just did in the rule of nines. Then to calculate the total amount of fluid to be infused, you multiply by 4 the patient's body weight multiplied by the total body surface area. And this will give you a figure of the total infusion required for the next 24 hours. Now, according to the Parkland formula, half the infusion is given in the first 8 hours, and then things can calm down a little bit, and the other half can be infused over the next 16 hours. What's the surgical and ICU management for someone with severe burns? Well, they may require mechanical ventilation with an endotracheal tube, usually a tracheostomy tube, because they're probably going to be on a little bit longer term ventilation. Feeding, nasogastric tube or a gastric tube, enteral gastrostomy, parenteral nutrition, it depends on how severely burnt the patient is. Debriding the scar or the eschar will become important. And again, things like compartment syndrome may occur as a result of edema. Skin grafts may be required, whether they be autografts from the patient and victim themselves or allografts from other donors. Then you may have to have reconstructive surgery to improve the appearance of the burn scars, possibly to prevent contractures and increase flexibility of the joints as the tissue heals and scarring occurs. And absolutely, rehabilitation will involve physical and occupational therapy to decrease contractures, increase flexibility and improve muscle strength. And absolutely, psychological and mental health issues will require support, especially in respect to severe burns and self-image issues. Now let's review. Can you name 3 life-threatening conditions which can occur as a result of chest trauma? The 3 life-threatening conditions are pneumothorax, tension pneumothorax, flail chest, cardiac tamponade, and more. You may have others. What's a pneumothorax? A pneumothorax is a collection of air in the pleural space. Pneumo, air, thorax, chest, chest, pleural cavity. Name one diagnostic procedure utilised for chest trauma and explain how it assists in diagnosis. Well, you've got chest x-ray. It can identify what caused the chest injury. It can identify a pneumothorax, hemothorax, tension pneumothorax. The same thing applies to CT, ultrasonography and MRI. The cardiac markers and ECG can identify whether there's any cardiac issues. And you can even throw in arterial blood gases, which can determine hypoxia, hypoventilation, respiratory acidosis, respiratory alkalosis, hyperventilation. Name and explain two common categories for chest trauma. Well, common categories we said were blunt and penetrating. They're the two most common. And as in the image that you can see, top picture, that looks like a seatbelt injury, which could have resulted in fractures, certainly cardiac contusion, certainly contusion possibly of the left lung. What is meant by the term thermal injury? Well, simply it's a burn. And you can now have burns that are first degree, second degree and third degree. Name three causes of a thermal injury, and there are numerous more. So you could include fire, scalds, contact, electrical, radiation and chemicals. Okay, that's the end of this presentation. Thank you for reviewing. If you think these are of any benefit to you, please recommend them to your colleagues and subscribe for the primary purpose being that you will be aware of more Dr. Manny Learnshops as they are uploaded. Thank you and God bless.